So, did you know that VTEs kill more patients each year than breast cancer, motor vehicle accidents, and HIV combined? The care and the expertise of the oncology nurse has powerful impacts on our patients and our families. And this is no different for oncology emergencies and bleeding and thrombosis. Patient family education, early recognition, and initiation of treatments are crucial to patient outcomes, and I believe that there's no more impactful role than the oncology nurse. The early and quick recognition of bleeding directly affects survival rates for our oncology patients.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Carrie Moore, Nurse Manager at the Medical University of South Carolina in Charleston, and member of the South Carolina Low Country ONS chapter, to discuss bleeding disorders and thrombosis and their current management and treatment strategies. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours by completing the evaluation we've linked in the episode notes. Thanks for joining me today, Carrie.
It's my pleasure. Thank you for including me.
So let's start by discussing bleeding disorders and their risks. Can you give us some background on common bleeding disorders in the oncology population and how they present?
Sure. So the oncology patient population has an increased risk of bleeding, and that's due to the disruptive hemostatic mechanisms caused by their tumors, caused by their disease processes, as well as caused by the systemic therapies that we give to these patients. Bleeding can present in many ways. Early signs of mild bleeding include bruising, ecchymosis, and petechiae, and often includes mucosal or skin surfaces. Then you may see more overt, mild, or severe presentations of bleeding. Basically, I like to say where there's a hole, there's a way. So this includes nosebleeds, coughing up blood, GI bleeds, which present as vomiting blood or coffee ground emesis, having abdominal pain, cramps, or bloody stools, or dark and tarry stools. And then hematuria, which can present with light pink to red urine or urine with multiple blood clots, vaginal bleeding, and then even bleeding or oozing around wounds or central venous catheters. Finally, you may see serious, more life-threatening bleeding, such as carotid rupture, which you could see massive hemorrhage, and intracranial hemorrhages that present with common signs such as headaches, confusion, paralysis, speech issues, and unconsciousness.
So, definitely a lot of things that our oncology nurses and listeners are going to have to keep their eye on and probably have seen in their practice. So, why is it so important to recognize these presenting signs of bleeding disorders early?
It's so important because the early and quick recognition of bleeding directly affects survival rates for our oncology patients. This is especially true if bleeding progresses to a life-threatening hemorrhagic event, and it can take quick action by the nurse to prevent this progression. I also think it's important because bleeding has a big effect on our patient's quality of life, especially because it can result in fatigue and weakness and increased hospitalizations.
So, Carrie, thinking about our patients that we take care of, and, there are definitely, if you're in an outpatient clinic, you're probably going to be caring for a lot of different diagnoses. So, are there certain patient populations that are at a higher risk of bleeding depending on their, cancer type or tumor diagnosis?
Yes, there are. And I'll break it down between solid tumor and malignant heme patients. So, for solid tumor patients, the risk of bleeding is increased with patients with advanced cancer stages, for patients with tumors that are close to large blood vessels, like our large head and neck carcinomas, and then mucin producing adenocarcinomas, such as those of lung and pancreas. All of our malignant hematology patients and our bone marrow transplant patients have a higher risk of bleeding, and that's because of the effects of these cancers and the treatments for these cancers on the bone marrow, which typically results in thrombocytopenia or low platelet count. But of our blood cancer group, the diagnosis with the highest risk of bleeding that nurses should be aware of is acute promyelocytic leukemia, or APL. APL is a unique subtype of leukemia, and although it's considered the most curable form of leukemia in the adult population, this diagnosis is linked with significant incidence of early death due to bleeding complications. In fact, a very large percentage of our APL patients will develop a hemorrhagic complication. And so I think oncology nurses should be aware of the risk of bleeding for especially this patient population during their induction or their initial course of treatment, and know that the most common death in APL is not their disease, but is hemorrhage, pulmonary hemorrhage, or intracranial hemorrhage.
That's really helpful. I think it's, important for our listeners, when they're taking care of their patients, that they're having to think about their treatments that they're getting and then the side effects from the treatments. But to know that, there are definitely certain diagnoses or tumors that put a patient at a higher risk for now another, side effect or issue with bleeding. I think it's important to kind of have that in your mind as you're, beginning to take care of whether it's, a patient that's newly diagnosed or just always kind of having that reminder that, okay, this particular patient group is someone that we need to keep an eye on for a bleeding risk.
Right.
So, other than cancer type, what factors might increase a patient's risk for a bleeding disorder?
I think nurses need to remember that platelet count is going to be your number one factor in predicting bleeding for our cancer patients. Our platelets are responsible for clotting the blood, and a normal platelet count can range from 150,000 to 450,000 platelets per microliter of blood. Patients who are thrombocytopenic or who have a low platelet count, especially below 10,000 or 20,000 microliters of blood, significantly increases the patient risk of bleeding. Besides the platelet count, potential risk factors that nurses should be aware of are broken down between patient-related factors such as their comorbidities, particularly obesity, chronic kidney disease. Then there's treatment-related factors such as the myelosuppressive chemotherapy agents that we use, or radiation therapy, or any anticoagulant therapies the patient are on. And then there's condition-related factors such as metastatic disease, fever, sepsis that can all increase the patient's risk of bleeding.
Now, let's talk about what is the diagnostic process for patients with suspected bleeding.
The diagnostic process should always start with a lab analysis, and this should include a complete blood count. So, your patient's hemoglobin and hematocrit levels are going to be used to monitor actual blood loss if the patient is bleeding. Your platelet levels and fibrinogen counts is also important lab values to review and replace if appropriate. And then I would also consider coagulation profiles and then a complete metabolic panel, specifically including liver function and enzyme assessments. You may also see imaging studies such as CT scans on the areas of the suspected bleed, and then maybe diagnostic procedures like endoscopies.
These are definitely all labs that, for a lot of oncology patients, are probably pretty routine. that they're going to be, having done prior to their treatment, but definitely some additional ones that you mentioned that, if the nurse is suspecting that there might be a bleeding risk or worried about that they can ask to have those additional testing added to their labs. So, what kind of prevention and treatment strategies for bleeding should an oncology nurse keep in mind? When they're thinking about the nursing considerations of this particular patient that they're taking care of.
Right. So I think most importantly, the nurse should consider is transfusion of blood products, whether that be red blood cells, platelets, plasma, or cryoprecipitate. Nurses must keenly monitor lab work, especially the complete blood count and fibrinogen levels, and follow their organizational and evidence based thresholds for the transfusion of blood products as appropriate. I also think it's important for nurses to remember that the response of these transfusions is very individualized per the patient and can be impacted by a variety of factors. But it's important for the nurse to consider that usually when they administer 1 unit of platelets, that can increase the patient's platelet count by 6 to 10,000 platelets per microliter of blood. Typical threshold protocols include keeping the patient's platelet count above 10,000 microliters of blood. And I've seen if the patient's febrile or if the patient's scheduled for a minor procedure, such as a bone marrow biopsy, that we may increase that threshold to 20,000. If the patient's have an invasive procedure, has one of the diagnoses in which you see more likely to see a bleed, or has a current bleed, the thresholds may increase again to be about 40 to 50 microliters of blood. For red blood cell infusion, I typically expect a hemoglobin count to be increased by 1 gram per deciliter in a non-bleeding patient. So if a patient's hemoglobin 6.8 and I transfuse a unit of blood, I'm expecting that as a nurse when I recheck that count to be around 7.8 if the patient's not bleeding. Again, it's very individualized per the patient. Usually protocol replacements for red blood cells are less than 7 or 8. However, I'm seeing due to the current blood shortage right now that impacts some of the thresholds as we're using 7 more than 8 right now because of the blood supply and demand. Nurses also should be aware that menstruation prevention is common, particularly in the bone marrow transplant patient population. And this is where they'll use hormonal therapy to stop menstruation from occurring in female patients. They also should consider other medications that are used to prevent bleeding. This includes medication drips that promote clotting, such as Amicar, and this can be given when platelet counts are sustained below 10,000 for an extended period, and our patients aren't responding to the platelet transfusions that we're administering, leaving them at a severe risk of bleeding. There's also medications that are built into our treatment plans. For example, Mesna, which is a bladder protectant, and that reduces the risk of hemorrhagic cystitis, which is a serious side effect of cancer chemotherapy agents, particularly ifosfamide. So overall, I think there are 4 key assessments that the nurse should always consider when monitoring patients who are at risk for bleeding. And these 4 include: 1, the patient's hemodynamic status; 2, their fluid status; 3, their vital signs; and 4, their oxygenation.
Carrie, we have a lot of new oncology nurses and new to oncology nurses that listen to the podcast. So tell me about what it might look like for a nurse who's newer based off of those 4 things you just mentioned, and they walk into their shift in the morning and, have this patient, look at their labs. Maybe their labs are, on the lower side, but they go in to do their assessment. What might that look like that would prompt them to think about there might be a bleeding issue going on with something that might not be a visible, noticeable bleeding that a patient is having?
Right. I think assessing your patients, particularly your vital signs, looking for any signs of hypotension or of tachycardia, noticing that your patients may seem a little anxious, they have pain in areas that they haven't complained before, and again, checking your labs from the morning and know that where you are as far as your platelet count, your hemoglobin count, and the risk associated that should give you a clue that you may need further assessments or monitoring to rule out a bleed.
Yeah, because sometimes I think, with these patients, it's easy if they're having that coffee ground emesis, or like you were mentioning earlier, if there's a hole, there's a way. And so it's easy if you can visually see it, but for a nurse to go in and just something seems not right, and as you said, a patient is anxious, you know, especially in patients that with diagnoses that you've mentioned at the beginning, this should definitely be something that, the nurse starts thinking about and kind of starts to process on maybe there's something going on that we can't see that is a bleeding issue.
Agreed. I think nurses must remember that the risk is there with this patient population and to go with their gut. If you feel like something's wrong, talk about it with your teams, decide how to move forward to rule anything out, especially a bleed in some of these particular, especially the hematologic malignancy patient population, in which it can be a common oncologic emergency.
Exactly. So let's talk about education for a little bit. How can an oncology nurse educate their patients about bleeding prevention? Because as I mentioned, you might be working in an outpatient setting where patients are coming in and you're treating them and then they're going home, and you're not going to be monitoring them all night long or, for the next few days. So, what kinds of education would you give to the patient and their caregiver related to bleeding prevention?
I think the education must circle the patient's daily life activities, especially patients who are thrombocytopenic. A high priority that I like to mention is fall prevention. I like to stress not only why the patient's at risk for falling, but more importantly, I highlight the risk of injury if the patient does fall. I make sure that the patient family completely understands that a head bump or a fall could have severe consequences with patients who are thrombocytopenic. Also, you want to teach them to avoid medications that increase their bleeding risk or interferes with the function of platelets, such as NSAIDs or aspirin products. And then there's common things to avoid that your patients and families should know about, which includes dental care, using soft toothbrushes, avoiding flossing, avoiding forceful nose blows. So asking them to try to blow their nose gently, avoiding rectal suppositories, enemas, rectal temperatures, and tampons. And then finally, just avoiding any activity that increases the patient risk of bleeding or injury.
Yeah, I think that those are such good points. And, when patients do go home, they don't think about those little things, such as the carpets or the little throw rugs that they have. And, when we're talking about fall prevention, or even if they have pets in the home or with little children, and how, you don't want to make their home be someplace that they aren't comfortable in or they're worried that something's going to happen. But it's good to think about all of those different potential hazards, as you might call them, for the patients when they are at home, and just the importance of knowing what those risks might be or what those signs of bleeding might be for them when they're at home. So let's move on to venous thromboembolism, which we'll call VTE from now on. Can you give us some background on VTE and how it presents?
VTE management is so important for the cancer patient population. Patients with cancer have a fourfold to sevenfold greater incidence of VTE than that of the general population. That's huge. In fact, many patients who present with a diagnosis of VTE also have indication for presence of a malignancy where they're first diagnosed with cancer. So VTE management for the cancer population is very important. Signs of symptoms of how it presents for deep vein thrombosis or DVT. Usually the patient will present with unilateral swelling of their extremity, whether that be the leg or arm. They'll have pain, warmth at the site, and or red or discolored skin. For pulmonary embolism or PEs, this is a little more acute presentation. We can see PEs alongside DVTs or alone, and these include shortness of breath, chest pain or pleural chest pain, anxiety, and cough as the most prevalent presentation signs.
Great. Talk a little bit about why it's so important to recognize these presenting signs of VTE early.
Early recognitions is so important because the risk of mortality for cancer patients. VTE alone is the second most frequent cause of death in patients with cancer, and it's the number one cause of death during chemotherapy. So it's very important that providers recognize the presenting signs of VTE early because the impact to survival rates are powerful, while the harm of VTE can be preventable.
So, what are the risk factors of thrombosis?
Well, the presence of malignancy alone is an independent risk factor for thrombosis, but other risk factors include patient-related factors such as their mobility status. Being immobile increases your risk. Smoking, age, gender, obesity, having a prior VT event also increases risk of reoccurrence. Then you have treatment-related factors such as recent surgeries, hospitalizations, and certain chemotherapy and biotherapy agents, as well as prior red blood cell transfusions. And finally, you have disease-related factors such as the site, stage of cancer, and whether there's a presence of metastasis.
So, you've talked about those early presenting signs of VTE. What is the diagnostic process for a patient who you suspect having a VTE?
So, similar to bleeding, the diagnostic process for VTE includes both lab work and imaging. Particularly the D-dimer test has a high sensitivity to the presence of VTE, so you'll frequently see that when ruling out DVTs. And then if the D-dimer is positive, future imaging such as a venous duplex ultrasound is common for DVT. And then for our PEs, we often see chest CT angiography and ventilation perfusion VQ scans as the recommended diagnostic workup. You may also see ABGs or EKGs to rule out other concerns while working up for a PE.
Are there strategies that oncology nurses can use to prevent or treat a thrombosis in a patient with cancer?
Yeah, patient education is so significant. Nurses should instruct their patients the signs and symptoms of VTE so that they can monitor at home and know when to call their providers. It's also important to teach patients preventive measures such as avoiding prolonged sitting, elevating legs when in bed, ambulating early and often, and using devices like their incentive spirometers and compression devices at home. For treatment of cancer associated thrombosis, low molecular weight heparin is the first line of anticoagulant therapy. So, patients and caregivers have to learn how to give subcutaneous injections at home. So, ensuring that the patients and the family members feel comfortable with administering sub-Q injection is so important for the adherence of these critical medications.
Great. Those are such good points for nurses to think about and to really be able to give their patients and, like you said, educate them and how important that is. Are there any gero-oncology considerations for bleeding or thrombosis that you could talk about?
There are the risk of bleeding and thrombosis are much higher for our older adult patient population. And not only is the risk higher, but the management of anticoagulant drugs becomes a little more complicated with this population because of multiple factors, which include polypharmacy, drug to drug interactions, drug to food interactions, non adherence, and comorbidities that increase with age, such as chronic kidney disease. The risk of falls increase with the age of our patients as well, so that's something important to remember. And then overall, for the gero-oncology patient population, their skin, their blood vessels become more fragile as we age, and the side effects of the cancer treatments can be harsher on this patient population as well.
Carrie, it has been a real pleasure talking with you and just the wealth of information that you've provided to our listeners about bleeding and thrombosis with patients that do have cancer. So I just want to finish up our discussion with a few questions, and we're going to do those in a real quick fire manner. And the first one that I have for you is, what are common misconceptions about bleeding and thrombosis?
A common misconception is that some may believe that bleeding and thrombosis are mutually exclusive, but sometimes patients have both bleeding and thrombosis at the same time. A great example is disseminated intravascular coagulation, or DIC. I think of DIC as an oxymoron disorder. It's a clotting disorder that results in uncontrollable bleeding.
Next, what's something about these oncologic emergencies that's not often discussed, but you wish people knew more about?
So, did you know that VTEs kill more patients each year than breast cancer, motor vehicle accidents, and HIV combined? It's a serious disorder, and bleeding in VTE cannot be downplayed by patients or providers. Changes can be so subtle, so close attention is warranted by the oncology nurse. And I think that the oncology nurse's role in education patients and families on the risk factors of VTE, as well as their assessment skills and monitoring, directly impacts survival rates when it comes to these oncologic emergencies.
What additional training or education do oncology nurses need to manage patients with bleeding disorders and thrombosis?
Oncology nurses are high customers of our friends in the blood bank, so they must have additional training in blood product transfusion and administration. This includes monitoring lab work, transfusion reactions, HLA matching, and being aware of the evidence based thresholds for blood product administration. They also should have additional education on the administration of high alert anticoagulant medications like heparin and clotting promoters such as Amicard drips. Effective anticoagulation education is imperative given the potential harm associated with the use of these medications.
Great. And what are some additional resources for patients and providers who want to learn more about bleeding disorders and thrombosis?
For providers, I always recommend the Clinical Journal of Oncology nursing articles, and then the Oncology Nursing Society Oncology Emergency Resources, as well as staying current on drug, food, and natural supplement interactions that can impact bleeding and clotting. For patients, there's several great resources, one being the American Cancer Society, who has patient information within their side effect material. The CDC has VTE blood clots and cancer on their webpage, which has great patient education material. And then I always recommend the Leukemia and Lymphoma Society, which has great general resources as well.
Great. Again, Carrie, thank you so much for your time, your expertise, and all of the great information that you've given to us today on this onc emergency. There are so many things that oncology nurses need to be aware of and be prepared to experience with their patients that are going through treatment for a cancer diagnosis. And this has been very helpful. Do you have any final comments for us today?
In conclusion, I'd like to recognize that the care and the expertise of the oncology nurse has powerful impacts on our patients and our families. And this is no different for oncology emergencies and bleeding and thrombosis. Patient and family education, early recognition, and initiation of treatments are crucial to patient outcomes, and I believe that there's no more impactful role than the oncology nurse.
Thank you for that, Carrie, and thanks for joining us today.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.